Thank you very much, Mr. Chairman. It's a pleasure to be with you here today. My name is Yasser Khatib. I'm an orthopedic surgeon from the outskirts of Sydney around the Blue Mountains. And this is our hospital, Nepean Hospital, where for my sins I do a lot of on-call, and therefore I end up with a lot of dealing with a lot of periprosthetic fractures. It's not bad because it gives you an instant revision practice. Periprosthetic fractures, as we heard, are becoming an epidemic, but they are as old as hip replacements themselves. The first report is made in 1954 by Horowitz and Lenoble, and they showed that there was a fracture around a hemiarthroplasty, which they fixed with screws and cables and then reinserted their prosthesis. And of course, as hip replacements became more popular, the cases continued to be reported of fracture. When we talk about fracture, it's mostly around the femoral component of a hip replacement. The fractures can be intraoperative or postoperative, and they vary in reports, but roughly around 1% for all comers. That's been reported in the Mayo experience, where cemented hips had significantly lower rates in primary and revision arthroplasty compared to uncemented stems. What about the Australian registry experience? The data now is collected for 14 years. Shows that it's the second commonest reason for revision of hemiarthroplasties, about 19% of the time. And of course, all of those will happen around a femoral prosthesis. In a hip replacement, most will occur around the femoral prosthesis, and it's the third commonest reason for revision after loosening and dislocation. And of course, that's 15% including metallosis. So if you take out metallosis, it's a higher percentage. Rates are increasing, as we've heard, increasing age, increasing use of hip replacements. Patients are more active. There is more chance for high trauma energy or high energy injuries. And we're also dealing with some of the old hips that now have established loosening, a lysis, and poor bone stock, which are more predisposed to having a fracture. Again, the risk of that is around 1% in large series from the Mayo Clinic followed up for 30 years, and 4% in revision surgery. Lindell looked at the Swedish registry and tried to estimate what the risk or what the future risk of a periprosthetic femoral fracture would be. And from his calculations, he arrived at a risk of 0.6%. But that is mostly in a registry which has mostly cemented components. And he also reported that this could be underestimated because Vancouver A and C fractures hardly ever get revised. So what about them? A femoral stem design, we already know, has and plays a difference because cemented femurs do better in terms of periprosthetic fractures compared to uncemented femurs. A couple of months ago, Haddad published a systematic review and meta-analysis of 17 studies. He studied roughly 1,700 periprosthetic fractures in a large cohort of reported cases. Again, arrived at the magical 1% rate of periprosthetic fracture. But he noted that cemented hips did better than uncemented prostheses, but that not all cemented stems are the same. There is slight differences, but they were not statistically significant. We've already seen the slide a couple of days ago, and the design of the uncemented stem tends to play more of a role. Single wedge and double wedge has significantly higher rate of fracture or risk of fracture compared to tapered and fully coated stems, and anatomic stems were somewhere in the middle. Classification system, the Vancouver system is the workhorse for this. Type A fractures are around the trochanters, so greater and lesser trochanters. Usually these are stable. A type B is around the body of the stem, and they're the main ones that we tend to fix or revise. A B1 is with a stable stem. B2 is the stem is loose, and a B3 is in the presence of poor proximal bone stock. Type C can be treated independently as it is distal to the stem. Other systems exist, but they don't roll off the tongue like the Vancouver system. This is a couple of x-rays of a type A fracture, one around the lesser and one around the greater trochanter. Usually we don't need to fix them, but occasionally there is trochanteric pain or fear of trochanteric escape, and they can be fixed. What about type B fractures? Well, B1, you must assess intraoperatively to make sure that the stem is stable. You must be prepared either to fix or revise this. So in this fracture, it's assessed intraoperatively, treated with cable plate, augmented with some screws, and it goes on to heal nicely. The newer generation of plates allow you to shoot variable angle screws that can sometimes be fired across or around the proximal part of the prosthesis and give you better bone purchase. But again, it's limited by how much bone stock you have proximally. Now, in terms of revision of femoral components in a type B fracture, you have to assess intraoperatively, and like I said, you have to have everything. You have to have multiple plans when you're going in there to fix or to treat these fractures. This one can look deceivingly simple, but when you go inside, it is far more complex. You end up removing the stem, preparing for a hip replacement, and arguably here, we should have used a longer stem. This is a ZMR prosthesis with fixed with a trochanteric plate as well that went on, luckily, to heal. But should you fix all B1 fractures just because the stem is stable? Probably not. Transverse and short oblique fractures represent a challenge. This is an octogenarian who had a stress fracture from chronic bisphosphonate therapy. You can see the hypertrophied lateral cortex. This stem is rock solid and has been functioning very well up until the time of her fracture. So I thought it'd be a shame to remove this well-functioning hip. Let me fix it. I got an anatomic reduction and I was quite pleased with it. But she wasn't 3 months down the track. You can see all the stresses are concentrated on one point, and in hindsight, this fracture was probably not going to heal, despite my best attempts. So now she's more happy after converting it to a long stem revision type prosthesis, a ZMR prosthesis, where I obtain distal purchase with the stem and make sure that's nice and solid, and then build on the proximal components of the hip and fix the fracture around it. So be ready to have everything. Now in type B2, the decision process is a little bit easier because you know the stem is unstable and therefore it will need to be removed and revised. Type C fractures, thank Rami for these slides. As we've heard, usually even with poor bone stock, you can get some distal purchase, and again you can build a good revision hip replacement from there. Type C fractures can be treated independently, but don't be lulled into a false sense of security. Sometimes things are more complex than they are. This is an interprosthetic fracture, and you try to fix it, get fixation whichever way you can. Take-home messages, be prepared, have multiple plans, A, B, C, have lots of inventory, be familiar with your revision prosthesis and know how to use it, have augments, have cortical strut grafts, have bone graft if you need it, and build from the stem upwards. What about acetabular fractures? Well, they are rare compared to femoral fractures. Mostly occur at the time of impaction of an uncemented cup. So take care with your technique. Make sure that your component is no more than 2 millimeters under-reamed. Also, the cup design does play a role. Elliptical cups put more pressure on the periphery of the acetabulum and therefore more likely to cause a fracture. Your impaction technique has to be meticulous, and you have to know what your bone stock you're dealing with. Of course, postoperative fractures can happen, especially in cases of osteolysis or poor bone stock. This is a case where patient continued to have pain after her surgery. When you look carefully, there's possibly a fracture there. She has a CT scan that confirms a transverse fracture of the acetabulum. And of course, as does happen in cases like that, it's not forgiving. She ends up coming back with a dislocation. So then she goes to theatre to have a closed reduction, which fails, and we plan for her to have a revision surgery. So she has a Cocker-Langenbach approach. The transverse acetabular fracture is plated, and a rough back gription cup is inserted with multiple screws. Now, other ways of treating that is with a cup cage construct, as we've heard before. You have to be familiar with the equipment, with your augments, and be prepared to use that. This is a more obvious fracture, And you can see that custom-made cups can also be a useful solution in this. So basically, you have to be prepared, have a good plan, and have multiple good backup plans. Be comfortable with your planning so that when you go in there, your stress levels are decreased, and you can enjoy your operating. Thank you.